my general message to people who do AI is to do two things. Ask the experts and ask children.
I've
Okay?
got some children.
I know.
I volunteer.
I know. But listen, remember, children are learning machines. Experts have corpuses of knowledge. If you combine an expert with a child, you'll get an incredible device because the child is a learning machine. The child will ask questions like, why are you doing this way? Take a child to a doctor's office and make them look at how billing is done. And they'll say, that's the stupidest thing I've ever seen in my life.
And they would be right.
And they would be right.
Welcome to the General Podcast, the show where there's no host, no script, just the best builders talking about what they do and why they do it.
I've always been a fan of yours. I think you know that. And we've met before. We've had coffee. I think for me, just finding somebody who is at the intersection of medicine and communications and has written books. We've had some similar trajectories in our careers. And you're obviously far more steeped on the clinical side, but both of us very passionate about just communication in general. And I love the way you write. So for me, it was a obvious heck yes.
Well, Chrissy, you're an amazing journalist. You've written widely, broadly. You cover issues that are dear to my heart, medicine, books, and most recently tech, and tech entrepreneurship. And so, generally speaking, I don't do a lot of podcasts. But they said, "Oh, Chrissy Farr's doing it," and I was like, "Okay, I'll do it." So that's my answer.
That's a huge compliment. I feel like the last time we met too, this whole AI thing was, it was certainly around. People were doing a lot of interesting stuff with machine learning, and you wrote about a lot of it in the books, but certainly not this LLM craze that we now see. So that's one of the first things that I wanted to talk to you about, because the clinical profession is about to see, I think, some absolutely transformational change. Some people think that AI is really just hype and all smoke and mirrors, but I think most people in the technology world that I spend time with do believe that this is something real and it's coming. And no one quite knows exactly how deep it's going to penetrate into medicine, but I think it's kind of widely already, starting. I go to conferences these days and I ask people, raise your hand if you're using AI or an LLM to diagnose yourself, and 2/3 of the room will say that they are, including physicians. A lot has changed since we last met. How are you feeling about this whole AI thing?
Well, the first thing is to distinguish between AI in general and LLMs. LLMs are large language models are just one aspect of many aspects of AI and machine learning. So I think would be helpful for listeners, especially people who are interested in medicine and science, to create a kind of typology of where and how medicine is intersecting with AI, including LLMs. The typology goes from simple to complex. The simplest one, which really has to do with language models and is related to what Richard Feynman called cargo cult medicine or cargo cult science. Cargo cult science is basically, in Feynman's idea, cargo cult science it's a long story, I won't describe why, but sort of science and medicine as enterprise objects. So nothing learning about it, nothing particularly deep about it, but just to make things easier, make life easier. So what does that mean? It means in science, it means things like grant writing, grants management, supply chain management, personnel management, data mining, data resources, etc. This isn't obviously very deep or complex work, but it's important work because it takes time away from the creative enterprise of science. And similarly in medicine, it would be things like notes and note writing, billing, and bill generation. These are huge pains.
It's just hours, absolutely
hours and hours of time, and lots of mistakes, etc. That happen. Now we have the beginning of ambient listening modes. these ambient listening modes feed into electronic medical records, EMRs. These EMRs can be scraped by language models, and so that you can do things like, that seem very mundane, but actually are very time consuming. So prior authorization, follow up, scheduling, etc. This is very low lying fruit, but this is either coming or already has come. If one is interested in these kinds of applications, they're gone. This is a vastly crowded space and is making great progress. It will be very useful, free up a lot of time for patients, for physicians to be able to deliver real care to patients, which is, of course, what patients want. Patients want you to talk to them. They don't want you to type on a computer while you're finding out, how they're doing. Moving onwards a little bit more, I would say there's the whole diagnostic sphere in medicine. And in science, it would be the data mining sphere, and they're analogous. So the diagnostic sphere in medicine is, a little bit more than just grant writing and EMR scraping and so forth, but really understanding a little bit more deeply about the corpus of knowledge, digesting that corpus of knowledge, and understanding what to do and how to do the next steps. Similarly, data mining is more than just just superficial things, but really getting deeply into the corpus of data, finding out what the structure of the data is. Are there outliers? Are there things that have been missed? What patterns there might be in the medicine? So continuing a little bit more deeply into this so-called typology. I think the next step is more than just diagnostics and more than just data mining. In medicine, it would be management, patient management. So recommendations about what to do, what trials are available, how to enroll in those trials, whether you qualify for them. And in science, it would be a little more deep insights into what the patterns of data show us, how they manifest each other, manifest in real life. What could they predict that is not already in the data? In other words, what is required, what is missing? A little more depth in sort of real learning capacity. Just to go one step deeper, I would say is management of, and this has already begun, management of teams and management of an AI research assistant in the case of science, or management of an AI nurse, or potentially even an AI doctor in the case of medicine.
And we're definitely seeing a lot of investment, especially into AI nursing.
Exactly, especially in
big
AI
companies
nursing.
there.
So exactly, so high level care, coordination of care. When you come back, can you get reminders? Can you, what do your values look like? What does it mean to do the next steps?
Yeah, I would just so much to unpack. And when you mentioned the management piece, I mean, you've spent so much time in really the history of medicine as well as the future. And sometimes I think about just all the diseases, the corpus of diseases that now we have, ideas of we've given them a name, we've described them, that 100 years ago we didn't even know they existed. So if a patient presented in a certain way, we might say it's hysteria or any number of things. And I think we have these same catch-all conditions today where we don't know what's wrong with someone and we say, oh, you have, a syndrome of some kind, and the patient doesn't feel very satisfied by that. So would you add in the actual work of diagnosing a patient, including whether or not we even recognize that the disease exists today within kind of the body of medical literature that we have, and how could that bridge both the medicine and the science?
Well, I think, you're talking about an ancient discipline called nosology, which is, of course, the classification of diseases. Nosology is changing all the time. What we used to think of, this is a headache, is now 1,000 different headaches.
Or cancer,
Or
which
cancers,
you've
1,000
written about.
different cancers. And even those 1,000 different cancers are becoming 1,000 different cancers. So absolutely, I think this is an area where AI can handle that information. Human beings really cannot. This reaches the limits of human knowledge. Databases can handle it, but AI can handle it better because it can discern sub patterns that a simple computational algorithm cannot discern. I'll just give you two more, and I'll come back to this idea. The two more are the two exciting ones, or I should say three more. One of them goes back to Thomas Kuhn and the Kuhn hypothesis of, can you make revolutionary, not evolutionary, but revolutionary predictions about the structure of science or medicine? So, in other words, can you synthesize entire corpuses of knowledge, entire fields of data into something that will produce more than the sum of its parts? I mean, think about what happened in physics. Think about what's happened in, let's say, electricity and magnetism, which were thought to be completely two different fields until someone like Maxwell figured out that, in fact, they're two sides of the same coin. There are probably in the universe of science, biomedical sciences inclusive, fields that seem very disparate today, but are actually two sides of the same coin or manifestations of the same field. That's a revolutionary kind of idea. And I think now we're looking at the real future and saying, listen, can AI digest a corpus of knowledge and generate truly revolutionary insights into fields just like Maxwell did? The next one it has to do with the other great luminary of scientific history, Karl Popper. And Popper was, of course, generated the idea of the falsifiability hypothesis, that a hypothesis in science is not a hypothesis until it can generate its own uh, falsifiable predictions. In other words, if you tell me I have a hypothesis in science, you should also be able to tell me how to falsify it. What would be the ways in which I could prove you wrong? I just did an exercise yesterday. It's an interesting exercise. I typed into Google Gemini. I said, what would be, how could I falsify the idea that a rat in an experiment knows its way around a maze? This was my prompt. I gave it more detailed prompts. I'm just giving a very high level prompt.
Mm-hmm.
The answer was really surprising. It gave me a whole series of ideas about how I could falsify it. I could change the nature of the maze. I could change the colors of the windows or the doors in the maze. I could visually reorient it,
Turn the lights off.
turn the lights off, etc. Interestingly, what it didn't give me was actually something very interesting. A scientist named Young years ago did this experiment, and he found that the rats always found their way out in the maze. And he
Give
was,
the rats more credit, I guess.
I know, it's a great story because he was puzzled. He changed the doors, he changed the orientation, he changed everything. And then he learned that the way that they were finding their way around the maze was that as they moved, the sound that they made on the ticking sound that they made as their legs moved was a guide. They could use that ticking. They had made a acoustic map of the maze in their brain, and the only way to get around that was to put the maze on a sandbox where all the sound was dulled. So
It's fascinating.
totally fascinating. So, but that's an example. Very soon, AI will come across Young's experiment. There's no doubt that it will, and say, now add one more dimension to it, falsifiability, and add sand or water to the maze, so that the sound it becomes irrelevant. But a great example of Parian idea. The final one I'll give is way out of the way, not ready here today, but I believe that in 10, 20, 30 odd years, there will be something in science and medicine similar to super agency. And by that, I mean that will not only generate hypotheses, not only generate falsifiability, not only do the corpus of data, but do what we consider really creative science, which is to say, ask the question, what is an important question? What is the way to answer that important question? Why is it not there yet? And how do we solve that question? That's a super agent kind of behavior. That is what real scientists do, real doctors do to some extent. We're not there yet. Hopefully, I won't be out of a job, um, but I think that's where we're going.
So let's talk a little bit more about this out of a job question, because you landed there and I was going there. I just had an interesting discussion with a friend of mine called Eric Lawson, who works at the private equity firm Towerbrook, and he's very interesting because he both knows a lot of the AI technologists, the Sam Altmans of the world, and he's also very close with payers and the health systems, and really makes it a point to kind of how do you kind of connect the dots between the two. And obviously it's early innings, but what he's argued is that there have been lots of technological revolutions that have really changed society over, the past centuries. I think obviously the printing press is a great example of that, and just what it did to democratize access to knowledge. But as he's looked back over these prior revolutions, he hasn't seen something that in his mind is so disruptive to what he calls the intelligentsia. The people who generally work at desks, who have made a living out of being academics, out of the study that they've done, the years of study. And I find that really fascinating. And what he believes is really the right career path to choose today is one that involves physical presence. So, take the example of a vulnerable, frail, elderly person who needs to be helped in and out of the bathtub. Until we have embodied AI, which could be several decades, there will need to be a person.
Not so far. I mean, robotics.
Or maybe it's sooner.
Robotics is moving pretty fast.
Okay, well, let's assume it's 10 years before that becomes super feasible, and then it takes time to roll that out into homes across the country. But to him, that seemed further off than, say, a physician or a healthcare administrator or somebody who is really relying on their own corpus of knowledge where, there's obviously human fallibility. It's been a really long time since most physicians went to medical school. They don't have the full corpus of medical texts and knowledge just instantly available to them, whereas, AI is rapidly moving in that direction. So do you agree with that thesis that it's coming after the intelligentsia, or do you think that there is something that maybe is off about it, or it's too simplistic?
I think it's a little simplistic in the sense that I'll give you a couple of examples. Corpus of knowledge is an important thing, and it's very valuable. Statistics are very valuable. Patients like statistics. They want the numbers. They want real numbers, but they also want care. They want that delivered to them with care. And they want what Stephen Gould once called there's a very famous essay by Gould in which he talks about the curve, the Gaussian curve that everyone inhabits. So, when you have a disease, you fall in a curve, right? So you're on the right side or the left side of the curve, right side being, even though the statistics are, et cetera, et cetera, et cetera, I believe that you'll be okay because of X, Y, or Z reasons. Some of them might be intuitive. Or you'll be on the right side of the curve, or you won't be okay because of X, Y, or Z reason. I think patients are looking for something more than bare statistics, even bare statistics from the corpus of knowledge. They're looking for the doctor to finally, having digested those statistics, whether they come from AI or they come from whatever, they're looking for things like reassurance.
But one could argue that LLMs, there's been studies that show that the empathy that's being provided through these LLMs is already keeping, I think, maybe even outpacing from a patient perspective what they are getting from their physicians. I mean,
that's partly because the physicians don't have time yet. But
yes. So that's where I was going to go is they don't have. And there was an interesting column that just came out a few months ago in Stat where a physician argued that all these studies were unfair because of the 8-minute visit that physicians currently are stuck with. It's not their preference. They don't want to treat patients in 8-minute intervals. It's the system that created that. So they would argue that if they were given more time and if the system was structured differently, the incentives were different, they would have room for that empathy.
Well, and it's also, remember, empathy is not something that's mechanical. It can be simulated mechanically. A machine could tell you that I'm really sorry. How can I help you more? Can I get you services? All of this can be done by a machine. Here's something that a machine can't do. It can't, at the end of a visit, touch you in a way that's non-threatening, non-sexual, but really touch you and say, I think it's going to be all right. I often say those words if I think they're correct, but I say it with some humility. I say, I think. I don't say, I know. These are the words I don't say. I don't say, statistics show us that you're going to be all right. I say, looking at you, I think you're going to be all right. And I think the next visit will tell us a lot more, because this is not a point of care. This is a journey that we start together. I'll be with you with you during this journey, and there'll be lots of forks in the road. It might be you'll be admitted to the hospital one day. You'll be short of breath another day. A medicine will not work for you a third day. And I say, that's going to be fine, because I'm going to be there with you in your journey.
You know, I think about journalism too, and I think about medicine, and these are all areas that clearly are going to be disrupted by AI. And where I've personally leaned is to think of myself as somebody who communicates what I am observing in the field. So I don't think that, and maybe I'm wrong, but I don't think an LLM has that institutional knowledge of having been around in an industry for 15 years and meeting, say, a CEO when they were first starting the business and hearing about all the things that they thought they could do and ended up not being able to do, and having that context for why they weren't successful in some areas and they were in others, and being able to share, I think, a lot of that, what I think of as really the in the field knowledge, that you have to have human experiences to be able to know these things. And I wonder about that with physicians as well, because, you know, look at oncology. If somebody gets a diagnosis of cancer, it's what you've seen as a clinician who's treated lots of patients with cancer that I would think is really what the patient may want to know. Like, what is it really like to have that diagnosis? How will I feel?
And there's a textural quality that's missing still.
Yes.
I mean, LLMs will, again, I don't want to only talk about LLMs. I want to talk about discovery as well. LLMs have a lot of, and they will eventually capture texture, I think. But there's a textural element missing. Obviously, I mean, I do a lot of work with LLMs and I do a lot of work with AI in general. There's a textual quality that's missing. I'll give you two examples. One is patient comes to me and has a particular problem as a consequence of their cancer. Let's say their kidneys are not working, okay? I have 15 consultants that I can send them to. But I know from looking at this patient that this one particular consultant has the behavioral biology, has the bedside manner, the kind that will fit this patient. Another patient will be completely different. Another patient is, I'm all about numbers and statistics, and I want a person who tells me, et cetera, all the truths about my disease. I send them to different people. Now, eventually AI will capture. So this is what I call intuitive knowledge, learned knowledge. Of course, eventually LLMs will capture that because this is knowledge. Their job is to capture knowledge, but they're not there yet. And it's not clear to me how I would share that knowledge. That's the other problem. Would I write for Dr. Chelapati? I would say empathetic, but statistically savvy. On the other hand, can tell patients diagnoses about their disease in 15 minutes, as opposed to spending an hour with them, walking them through the science. In principle, I could type that into an LLM, but I'm not sure I could capture that. I know it. I know I've worked with this physician before. And then I'll give you a flip example.
It's almost instinct or something innate.
There's an instinctive quality about this. And yes, I think that in the end, if they are fed the information, they will capture that information. The question that I would ask in return is, what is the incentive for the true intelligentsia to feed that information into an LLM? Why would we put ourselves out of a job?
It's a fair point.
I can imagine getting help from an LLM to diagnose a patient. That helps me. I can imagine getting helping me with billing. I can't imagine, unless we decide as a society that we'll put all our intuitive boxes into a corpus of knowledge, which we could do, especially for future generations. We could do all of that. I just don't see the incentives aligning. Similarly, in science, I could put a lot of information, and I don't even need to put a lot of information. The machine will go and learn a lot of information. But I don't see myself putting my deepest intuitions into a machine. I won't even know how to do it. I make medicines. I make drugs. Okay? Some targets are considered undruggable so far. Maybe with machine learning, we can figure out, with AI, we can figure out how to, we're actually working on this right now. It's a problem that's a big problem. We're working on it right now. How am I approaching the problem? I'm approaching the problem in diverse ways. Sometimes I dream about it. Sometimes I wake up with an idea, I write it down, etc. I say, well, maybe a cyclical peptide or peptide-like drug will fit into this pocket.
I love that you dream about cyclical peptides.
What do you dream about?
Not that.
Okay, all right. Well, so sometimes I say, okay, maybe a cyclical peptide will fit in. And then I wake up and I write it down. Now, am I really incentivized to tell my ML that a cyclical peptide is likely to fit into that pocket? Not really. I'll try it. And that's passive learning. And maybe behind the scenes, surreptitiously, the model will say, oh, wait a second, he's been trying cyclical peptides. There must be something in there. So the next time I'm going to start generating cyclical peptides for him. Could be. I just don't see it happening.
So we touched a little bit on discovery, and I want to go deeper there. I've been, for years meeting with companies and spending time with companies that are focused on using AI for drug discovery. I think the first generation, not as successful for a lot of reasons that we can talk about. This new generation seems to be more sophisticated in the approach. I think more recognizing the strengths that a lot of these biotech and pharma companies already have within their own teams. They have their own technology teams in-house, which I think was perhaps missed with some of the prior companies in this space. But then there's also, some interesting stuff I've seen around things like drug repurposing. So using a drug for a different purpose than we use it for today, could it be used to treat a condition? There's so many rare diseases that have no treatments whatsoever. Could we use AI to, dig into this trove of already FDA-approved drugs that have gone through trials and see if there is another purpose for that drug? And I think that's a really interesting use case as well. And it's still early days, but I'm equally fascinated by that. So would love your thoughts on just where you see discovery going and what has been learned from, say, the first generation to try to do this to what we're seeing today.
Well, let me answer your last question first, which is about drug repurposing. I mean, David Feigenbaum has written a wonderful book about this.
I just saw his talk.
Yeah. So there's certainly examples of that. I mean, if you were to ask me, I think that the pharmacopoeia that we have, the total universe of drugs that we have for human diseases is pretty small. Chemical space is really vast, more than people say sometimes, more than the stars in the Milky Way. And we are operating on a tiny, tiny little arena of chemical space. So there's lots more chemical matter to discover. So yes, I absolutely, I believe in repurposing drugs, but I think given the smallness of the chemical space and the very particular kinds of diseases that we're talking about, rare diseases, it's not clear how much traction we can get out of that. But now we can come to the question of discovery. The first generation of discovery in AI really used, I would say, first generation tools. And the first generation tools were not great tools. So they were tools like, let's take known chemical space. So again, not diversify around chemical space. By docking, I mean fit the drug like a puzzle piece into the protein, which is maybe the causal problem, and do it again and again, like solving a puzzle by taking one piece, putting it in, saying no, it doesn't fit. Second piece, putting it in, no, doesn't fit, et cetera, until you reach a billion pieces. That's not real AI. That's computationally intensive drug discovery using, um, a library of compounds. We're now into the second and third generation of AI, where we're doing much, much more interesting things. Things like asking the question, if you take a protein, can you do an abstraction of it? Can you do what's feature extraction? And say, let me forget about the protein. Let me do an extraction of the features of the protein. Here's a wall. If you imagine a pocket where the drug might fit, here's a wall that is electrically charged. Here's a wall that's not. Here's another wall that's very tight. Here's a wall, etc. And then using that feature extraction to go back into the library and ask the question, what molecules fit that feature extraction? That would be a kind of a second generation approach. A third generation approach, which I think is the most interesting, is to say, okay, let me feature extract, and then let me grow the medicine, grow meaning generatively, and this is where generative chemistry comes in. Let me grow the medicine just like an ivy plant grows its roots into a little crevice in the wall. It feels around. It says, "Oh, okay, there's a little crevice over here. I'm going to extend a root over here. No, it doesn't fit. I'm going to withdraw it. I'm going to go this way,
I
etc.,
love that.
etc."
I love that image.
Yeah, that's generative chemistry. And then you still need medical chemists saying, "Oh, you've come up with a structure that can't be made. It's not energetically feasible. Throw that one out." Okay? So there's now the third example that I described is, of course, what we're very interested in. And it is an example in which we're really using the learning capacity of AI, not using just the computational brute force capacity. Take one piece, take it out, take a second piece, take it out. That's not how you and I solve puzzles. If you think about how you and I solve, how your child solves a puzzle, this is why I think it's very important. My general message to people who do AI is to do two things: ask the experts and ask children.
I've
Okay?
got some children.
I know.
I volunteer.
I know. But listen, remember, children are learning machines. Experts have corpuses of knowledge. If you combine an expert with a child, you'll get an incredible device, because the child is a learning machine. The child will ask questions like, "Why are you doing this way?" If you go to take a child to a doctor's office and make them look at how billing is done, and they'll say, "That's the stupidest thing I've ever seen in my
And
life."
they would be right.
And they would be right.
Wow, I love that. It's really fascinating advice. But what about the role of just we've touched on the system. Like if we were to take what you just said a little bit further, which is why do we do this stupid thing with the way that we do billing? The real answer is because the system requires it, and
Yes.
the system has its own incentives, and it has its own messed up, companies that are operating in ways that make absolutely no sense. But it's about money, and it's about how they make money, and all the things that are wrong about the system. And taking that back to discovery, I mean, it's been said many times that it costs $1 billion to create a new drug, and that is the problem with creating drugs for rare diseases. In a nutshell, although it's far more complex than that. And when you add up all the rare diseases, it's actually a very large number of people affected. But then with these strategies that we've been discussing, is there a way, do you think, just by using different tools and a different methodology to start to bring the cost down? Or will we forever kind of face a system and its messed up incentives that may thwart some of this progress that a child would say makes all the sense in the world?
So I think we're already there. I think that if you are a pharmaceutical company and you're not using computational and AI tools, you're behind the ball. And you need to start using them today. You need to start getting to know them, because otherwise you're going to be not just behind the ball, you're going to be far behind the ball. That doesn't mean that you fire your med chemist. Your med chemist, I told you, the things that AI can come up with can be absurd. Your med chemist can take one look at it and say, that's never going to work. That's got, a pyrazole ring that is going to react immediately and get destroyed in blood. You still need your med chemists. Don't fire them. But you need an AI team, because, as I said, your med chemist can only come up with chemical matter in a limited context. And they're using their corpus of knowledge, which is also limited and is slowly expiring because new medicines are coming out. I mean, yesterday is a good example. I was looking at a AI-generated compound that had a problem. There was a liability. We call them liabilities. They're basically a problem with the compound. And it was very soluble in fat and oil, but was very insoluble in water. Now, that's a problem because ultimately, even though the drugs have to pass through into cells, which means that they have to be at least somewhat soluble in fat, because otherwise they can't move through the cell membrane, which is made out of fat. But you can't formulate the drug because ultimately you don't swallow a drug in fat, right? You swallow a drug in water, either as a liquid or a suspension or an IV or whatever. And
I can imagine, I've got this image of somebody putting a drug in a giant cube of butter and
exactly having the butter for exactly. The problem is that the butter then gets emulsified in your stomach, and then you're back in water.
Don't do that at home.
Don't do that at home. Exactly. But anyway, it doesn't matter. And then the med chemist said, there's this new class of molecules which you can substitute for one of the molecules that we had, or one of the little pieces that we had, and said, there's a new class of molecules which will solve your problem. And we're trying them now. Will it work? I don't know. But that's an example of a med chemist and the AI collaborating. The AI generated something that was very helpful, but had a problem. The med chemist had a corpus of knowledge and was able to use that corpus of knowledge, new knowledge, in fact, because they had to keep up with the literature. You can't rest on your laurels and go home, but was able to solve that problem.
So I'm going to tell you a little bit about what worries me, and then I'd love your thought on this as well. I had a friend over a few weeks ago who used to work at Google on some of the self-driving autonomous vehicle stuff. And they had this one weekend, and this is a story that was shared with me, so may not be 1,000% accurate for anybody listening who has worked at Google. But I think the idea behind it is important, which is that some of the engineers were basically told to drive around a Waymo for a weekend and test it out. But they were told...
But they were not driving. They were sitting in the backseat.
No, they were told to test it out, but then always, be present, keep your eye on the road. And most importantly is have your hands on the steering wheel. And so I'm sure you can guess what happened. They had their hands on the steering wheel for about 5 minutes and then started futzing around with social media, and then started having chats and rolling down the window and, talking to friends and you name it, just kind of rolling around kind of fully autonomous in this vehicle, doing exactly what you would expect human beings to do. And I think the point of this story is that we can get quite lazy when faced with things that seem like they're basically trusted. When put in a mode of being fully autonomous, we have this tendency to just kind of go with it. And you've seen that as well with kind of airline pilots over time forgetting how to fly planes. And so what worries me is that
children forgetting how to read.
Yes. So like, what if we've created something that maybe is 95% correct and 5% totally missing context, or missing something that is fundamentally true about science. And then over time it gets to 96, 97, 98. And then when do we get to the point where the company either says, let's fire the med chemists because this is basically good enough, or the med chemists just feel that most of the time they're just ticking the box and saying, let's go with it, and then stop really interrogating.
So you're asking a very important question. But remember, in medicine, I can talk about the narrow domain of medicine, which is different from Waymo. The narrow domain of medicine and medical uh, innovation is that the readout is a human clinical trial. And the human clinical trial, if it fails, means the company is wiped out, there's no future, you've lost $1 billion. So the stakes in a human clinical trial, first of all, are highly unbiased. It's a phase 3, you're blinded, it's placebo controlled, it has a statistical measure, it has endpoints, et cetera, et cetera. And there's a history behind this. The history behind this was, the randomized clinical trial, the placebo-controlled clinical trial, was only invented in the 1950s by many people, including Austin Bradford Hill. I write about it in my book, precisely for this reason, precisely for the reason that human beings can become lazy, they can become biased, they can become, they can lose sight of everything. But statistics and clinical trials in statistics don't lie. They can't lie. And so it'll take one example when the med chemist was sleeping at the wheel, in the mixed metaphors with your Waymo, but was sleeping at the wheel. The trial didn't work because of a formulation problem. And then all of a sudden, all the drug companies will be like, go get the med chemist back. The reason I'm making this distinction is that in many spheres of our lives, we don't use very rigorous methods for evaluation. If, let's say, Waymo launched an experiment for whatever reason, in which they asked the question, was the minutia of accuracy the same between drivers who did not or did get off the wheel? It was true experiment. They generated true knowledge, and there was true difference. They would all of a sudden say, no, 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 you have to keep your hands on the wheel because we aren't there yet. So what I'm trying to say is that there will always be examples where the stakes are so high. Airline pilots, one plane crashes, and the airline pilot has, remember, is no longer has their hands off the wheel, and they're two, in case one of them falls asleep or has a heart attack, right? So when stakes are high enough, and they should be, I think human beings have the capacity to invent backup systems and invent systems in which they don't make themselves obsolete.
And do you think that that is also true on the kind of pure clinical diagnostic side, where clinical decision support, that's certainly going to be in our future, it already is. You're a physician, you're looking at a series of kind of what are the potential options of treatment that I can prescribe? What are the options around next steps? Some of it generated by you, some of it by an LLM that's ingested a lot of information. At some point, perhaps the LLM suggestions start kind of becoming more and more routine, maybe more and more trusted. Do you worry that there comes a sort of natural endpoint to this where it is just deferred to?
Yeah, I think that you're pointing out a much more complex example where the stakes are just as high for the patient, but are not as high in the sense that the patient won't die if they get the wrong diagnosis initially, and then they get redirected. Once you find out that they haven't. I think there's a worry about that scenario. This is the stakes are not that high if children don't learn calculus, right? By the way, if you type into any of these programs, they'll do calculus for you.
I don't think I even remember calculus, honestly.
It doesn't matter. So that's a good example, right? The stakes weren't that high, right? We know that some children need to learn calculus. Not everyone, but some children need to learn calculus. Not everyone. Some children need to learn statistics. Some children need to learn how to write. And I suspect that what's going to happen is that what will end up, here's the optimistic vision. The optimistic vision is that they won't learn how to draw in the mechanical sense, but they'll still be artists because human beings will perceive the mechanical drawing so quickly that we become bored of it. Similarly, in the sciences, human beings will become so bored of the routine um, corpus of knowledge digestions that will become bored of it and say, listen, we better start teaching kids science again. In the case of, very powerful, so medical diagnostics is a very interesting example because it relies very strongly on a large corpus of knowledge, right? And the larger it is, the better you are at the medical diagnostics. So there are some serious areas where the idea of obsolescence becomes a dangerous idea, because obsolescence means that you don't contribute further to the corpus of knowledge. Remember, at least LLMs, not generative AI, but at least LLMs are still dependent on the corpus of knowledge. I keep coming back to this word corpus. It seems like I'm sort of saying this over and over again. AI in the LLMs is only as good as what it's fed. If we stopped writing books tomorrow, which we could, all of a sudden we'd bring this whole engine to a halt. If I didn't write a new version of Emperor of All Maladies tomorrow, right, it would be very hard for an engine to digest what has happened over the last 15 odd years. It could do it. It would probably do a bad job of it. It would be biased. People write lots of articles about how great their inventions are. They don't turn out to be that great. Someone needs to do some sort of like judgment on it, et cetera, et cetera. So I suspect what's going to happen is that human beings will soon realize that it's a human-fed LLM machine, generative AI separately. But as far as language models are concerned, without human feeding, I don't think we get very far.
For those listening to this who may be thinking about a career in the medical profession, what specialty would you tell them to choose? What specialty would you tell them to avoid? I will say that I often hear radiology, pathology is in the avoid camp. Sometimes primary care, and then what do you choose? It seems like everybody's getting boarded right now in obesity medicine. And we also see kind of specialties of lifestyle remaining popular. But I think this kind of AI aspect is going to, that's a big reason why the avoid specialties have been put on that list. So what would you advise somebody?
I don't tell anyone to avoid anything. What I just tell them is, I say to them, look, in whatever field of medicine you're going to go into, you now require twice as much creativity, which is a good thing, by the way. Medical people felt as if they were being sidelined in terms of their creative profession, the creative knowledge. You'll have to use twice as much as your creativity. Hopefully, you'll have your time will be freed up. So you'll have time to exercise that creativity. But third, and most important, and I wrote a piece about this in the Times way back when, I often tell people, great, choose pathology, fine. But if you choose pathology, go deeply into one arena of pathology where you can apply true creative knowledge and generate true creative knowledge. I always say that the word generate is most important, because remember, it's the generation that's feeding the AI. And as long as we can generate knowledge, not just assimilate knowledge, not just copy knowledge, but generate true knowledge, I think we're safe.
I love that. And I also would add there that I think medicine has not been as entrepreneurial.
Yes.
In the last, since really the last 20 years. And I'm starting to see more of this opportunity, and part of it connected to the time and part of it connected to the efficiencies for physicians to be business people, to be entrepreneurially
and that's also
minded.
part of generating knowledge.
Yeah, exactly.
Different kind of knowledge, but it's generating knowledge.
We forget that it used to be a very entrepreneurial, you could be a small business owner. If you went into medicine, you could run a chain of practices. It's less that way. It's sad, but I think there is that massive opportunity ahead. Wow, what an incredible conversation as always.
Great, lovely to chat.
Yeah, we need to check back in and maybe say call it a year and just kind of see what's happened.
And let's see what's happening in a year.